Good morning, good afternoon, and good evening, all. Once again, a very warm welcome on behalf of MYT. We are very much looking forward to supporting you with today's Test and Learn series discussions, promising practices in collaborative planning for integrated campaigns. So I'm now delighted to hand over to Leah to welcome you to the session. Thank you.
Good evening, good afternoon, and good morning. It's my pleasure to welcome you to today's Test and Learn session hosted by the Health Campaign Effectiveness Coalition. My name is Leah Denise Wyatt. I am the Senior Associate Health Campaign Effectiveness Coalition Director and the host of today's session. Please take a moment to share which country you are joining from in the chat. And I'm going to pop my country in too. And I'm just going to wait for those to start rolling in. And while those come in and we see which countries we're joining from, for those who are new to the coalition or joining for the first time, we are a first ever partnership for cross-campaign collaboration. We foster learning and systems change and support implementation research that advances the testing and replication of evidence-based health campaign practices. The coalition develops guidelines and approaches that help health campaign practitioners improve their collaboration with country health systems. The Test and Learn series facilitates learning across health campaigns, fosters collaboration, and identifies systems change. This series highlights levers that have been tested in a quest to enable collective learning about how to improve coverage, equity, cost effectiveness, and health impact, all common areas of interest among health campaign actors. Today, we will take a sharp focus on what we are learning about collaborative planning for campaign integration, and with it, how decisions are made and the factors that enable and hinder this approach. By the end of today's session, we will have identified opportunities for campaigns to work collaboratively and what each one of us in the coalition can do to support change. I am going to ask our colleagues at MIT to pull up a brief poll so that we can get acquainted and gain a sense of our collective experience in collaborative planning. So if you can, please indicate whether you whether you have ever planned a campaign activity in collaboration with another campaign. So that would be true. Yes, I have planned campaign activities in collaboration with another campaign, or false or no, I have not planned a campaign activity with another campaign. There's no wrong answer here. And I'm just going to go ahead and ask MIT to show the results. Okay, great. So quite a few of us have, and for those of us who have not, really tune your ear to uh, the factors that may enable or hinder collaboration with another campaign. And for those who have, please do bring in your experience into our discussion. And if you're currently in the midst of collaborative planning, like right now, go ahead and put a 1 in the chat. If you are currently in the midst of collaborative planning, just go ahead and put a number 1 in the chat. Today, we will receive a presentation of promising practices in campaign planning for campaign integration generated by 8 local institutions in 6 different countries. The teams examine past, planned, and potential integrated campaigns. Keep in mind the practices are actions that planners, managers, and implementers across immunization, polio, malaria, vitamin A supplementation, and NTD campaigns can consider for improving the planning process and increasing campaign effectiveness. The presentation will be followed by a panel discussion with individuals of the coalition. The panel includes 2 women who lead efforts in their countries to contribute to this body of knowledge. After the panel, We will take a brief stretch break. When I say brief, I mean brief, a brief stretch break before we break into our discussion rooms. In those discussions, we will explore one, how decisions about integrated campaigns are made, and two, the extent to which global and national policies incentivize or hinder collaborative work. You can keep those questions in mind as we hear from Dr. Eva Bazant, Senior Associate Director of Research for the Health Campaign Effectiveness Program, and Carol McPhillips Tangum, Senior Public Health Evaluation Consultant for the Health Campaign Effectiveness Program. Dr. Bazant is an applied program evaluator and mixed methods researcher with 20 plus years of global health experience. Previously, at JPIGO, she served as a research team lead and senior monitoring, evaluation, and research advisor, collaborating with multidisciplinary teams working in maternal and newborn health, reproductive health and family planning, HIV and cervical cancer prevention, care and service demand, gender and disability services, mainly in sub-Saharan Africa. Carol McPhillips Tangum has 20 plus years of experience in research and evaluation. She has led teams of health educators, health service researchers, and data analysts in the design, implementation, and evaluation of health improvement and disease management programs for diverse populations. Carol focuses on health services research with an emphasis on survey research and program evaluation. Carol, Eva, over to you.
Hello and welcome. Thank you for joining us. I'm Eva Bazant, Senior Associate Director of Implementation Research, and I'm joined by my colleague, Carol McPhillips Tangum at the Health Campaign Effectiveness Program. And today in this Test and Learn series, we'll be discussing the promising practices in collaborative planning for integrated health campaigns. And over the next 25-30 minutes, we'll present some of the background in our approach, findings with a summary, and then we will invite panelists to help answer your questions. And in the second hour, have an interactive discussion with you. Okay, so why did we focus on health campaign integration? Well, in 2020, when we were starting up this program, our design team and many others on the coalition were concerned about COVID-19 having delayed many campaigns, and that low coverage of some interventions was being exacerbated. And it was believed that there may be opportunities to enhance efficiency and community acceptability of campaign interventions by offering more than one intervention through campaign integration. So that was something we wanted to explore. We were also noting great interest in this topic as shown in policy and strategy documents. For example, the WHO Neglected Tropical Disease Roadmap and the Immunization Agenda 2030. So this topic made its way into our research and learning agenda on our website through the help of our Scientific and Technical Advisory Committee and Campaign Integration Working Group. And we focus on integration in different ways. We believe partial integration is the collaboration of between two or more campaigns in the sharing of specific campaign activities or functions, but without that co-delivery of interventions, while full integration would be that collaboration and intervention of two interventions at the point of service. So we explored this early on in a technical brief, in a rapid review of the literature, and more recently we produced another technical brief on campaign integration in the Pan-American, in the countries in the Latin America region with our colleagues at the Pan American Health Organization. Next slide. So why focus on campaign pre-planning and planning? Well, we do know that planning is essential to successful campaigns, and it's especially critical for more complex integrated campaigns, and that planning is important for leading to action. So we wanted to be really deliberate about understanding this initial first phase of integrated campaigns so that others could benefit. There was little guidance at the time about how to exactly go about effective campaign pre-planning and planning in the areas of immunization, polio, malaria, vitamin A supplementation, and neglected tropical or infectious diseases. So we set out in low and middle income countries to support, next slide, the local institutions that were working with government agencies to identify those collaborative planning approaches for integrated health campaigns and to highlight the promising practices. We really wanted to understand the factors that enable or hinder collaborative campaign planning across these 5 health domains. Next slide. So we put out a call for case studies in November of 2020 and disseminated that through members of our coalition, including our Scientific and Technical Advisory Committee and Campaign Integration Working Group members who shared it with their networks. And of the proposals we received, 8 were funded. And all of these were organizations working closely with government agencies on the planning of integrated campaigns in one or more of the 5 domains I mentioned. And these were relatively short awards over 6 months. And each of these project teams conducted mixed method studies collecting quantitative and qualitative data, where they assessed diverse views of interested parties at all levels, including at the community level. Awardees submitted to HCE their case study in a template that was then reviewed by our technical teams and our communications teams for clear messaging. And we had the feedback of external reviewers, and then these documents went through a period of revision. And now the web pages are up on our website for each of the projects, and there's a downloadable report as well. And we're currently in the process of gathering the practical tools and resources that each of these awardees use so that we could be sharing them for wider appreciation and use. So from these 8 projects, we gleaned 65 promising practices. What we define as an action emerging from a case study that campaign planners or implementers should consider doing and building into plans. And this list is also on our website. From that point, we started grouping them together into categories in coding them and grouping them in Miro in a visual way based on what we were seeing, so more of an inductive process. We also looked at established campaign guidance documents, such as the World Health Organization Supplemental Immunization Activity SIA Guide and the Alliance for Malaria Prevention Toolkit to come up with a series of phases and activities that could serve as a framework for the promising practices. We received feedback on several occasions from a subgroup of the Campaign Integration Working Group members, both country level and global, at the global level. And then we came up with 10 high-level promising practices to encompass what we were seeing among all the 8 reports. So this is a description of the projects in 6 countries. And so the project teams included the University of the Andes in Colombia, FOSAD in Guinea, working closely with the immunization program, UNICEF, working closely with the Ghana Health Service, Ebola Health International in Nigeria, working with the malaria program, as well as Clinton Health Access Initiative, working in Nigeria in the immunization space. And then 2 projects in Uttar Pradesh looking at neglected tropical diseases PATH, and the India Institute for Health Management and Research, and also HEAL in Nepal. So the 4 of the projects were what we consider within domain, where they were looking at campaign integration, perhaps among 2 interventions within immunization or 2 interventions within malaria, while 4 projects were cross domains. And 2 of the projects looked at past integrated campaigns that were done on a large scale. One was accompanying a pilot study of 2 interventions, and then the rest were about assessing stakeholder views about potential integration and planned integrated campaigns in 2022. So with the promising practices and our look at established campaign guidance, we came up with what we thought was an organizing framework of a campaign planning and implementation cycle that would have 5 phases. The pre-planning and planning phase could start up to 5 years before an integrated campaign, some of those very early steps. The planning phase would be 6 to 9 months before the integrated campaign, preparation being those more immediate steps that would occur, then implementation, supervision, and monitoring to be followed by evaluation and post-campaign surveillance, and that there could be learning and adapting along the way. So this wheel shape we see in the next slide has been transferred to a table where you see the phases are here now in columns of pre-planning, planning, preparation, and implementation, supervision, and monitoring. That's really where our data were fitting into these phases. And next slide, we also came up with these 8 activities or functions that encapsulated the promising practices. And you'll see that the darker shaded cells are where we believe the activity function aligns best with that particular phase, acknowledging that a particular activity can continue on or even start in an earlier phase. And we do see digital tools and other innovations happening all along this time. So now I'll turn it over to Carol to present the findings.
Great, thank you, Eva. So it's my pleasure to share with you the 10 high-level promising practices that emerged from the case studies. The first 4 promising practices that I will be sharing relate most closely to the coordination and macro planning activities. So the first promising practice is to facilitate participatory decision-making by forming a coordinating body to oversee campaign integration and collaboration with regional and local coordinating bodies. So while coordinating bodies are commonly used in all types of campaigns, vertical campaigns, and so forth, they take on special importance and play an important role in integrated campaigns that involve either collaboration or campaign co-delivery of campaign commodities or interventions. So for example, in Ghana, UNICEF and the Ghana Health Services worked on polio and vitamin A supplementation, and they described the use of their Emergency Operations Center, or their EOC, as an intersectoral planning and implementation committee to support the really unique needs of integrated health campaigns. They also used subnational committees to provide more of the day-to-day monitoring and support to campaigns. And they felt that using some of those subnational campaign coordinating bodies were more likely to reflect the needs and cultural context of the community. The focus of those more day-to-day types of committees is really on reviewing daily performance and taking action to improve operations specific to campaign integration. The second promising practice, which you can see here on the slide, is to maximize campaign effectiveness by ensuring the integrated campaign planning that responds to the health situation of the community and assessing readiness or preparation for campaign integration. So to this point, some of the case study awardees described the use of readiness or preparedness assessments that were used really to assess whether a community or a locale was truly ready to implement an integrated campaign. So here you can see a screenshot, just the top part of a campaign implementation readiness dashboard. This was developed by the Clinton Health Access Initiative, or CHI, related to integrating a campaign for measles and meningitis. So this is just one example of the type of tools that are emerging from the case studies that we sponsored and what the awardees were able to produce and use. Moving on then, the third and fourth promising practices are also related mainly to coordination and macro planning. Promising practice number 3 is to maximize the integrated campaign potentials for success by embracing the learnings of previously successful campaign platforms and approaches that have been used to build acceptance of integrated campaigns, sometimes by pairing the campaign with another familiar or popular campaign. So for example, in Uttar Pradesh, India, the awardee path was exploring campaign integration in NTDs, STH and LF particularly, and they noted that the Pulse Polio campaign has been really the biggest and the most successful campaign of its time. And the learnings of the Pulse Polio campaign had already been adopted to enhance the effectiveness of other campaigns, such as those for measles and Japanese encephalitis. The case study awardee, though, in this case, noted that some of the learnings from the Pulse Polio campaign, which included things like creating review mechanisms at all different levels, conducting daily briefings with supervisors, field workers, and officials, using interactive methods for capacity building, strengthening and monitoring and evaluation, and involving relevant stakeholders for advocacy. These all could be very helpful in the delivery of integrated campaigns as well. And then promising practice number 4 is to enable timely and context-specific campaign decisions by decentralizing decision-making when appropriate to enable flexibility. And we certainly recognize that some campaign decision-making absolutely has to happen at the central level, but our case study awardees in Guinea suggested that decentralizing some campaign decisions could enhance efficiency. Promising practice number 5 and 6 relate mostly to stakeholder and community engagement. Number 5 is to secure broad participation, commitment, and buy-in early in the campaign planning process by engaging stakeholders at all levels, including national, regional, district, local community. For example, in Colombia, the University of the Andes worked alongside the Ministry of Health in a very remote province of the Amazon on an integrated NTD campaign. And they underscored the importance of making campaign decisions in a very participatory manner and obtaining endorsement by all stakeholders. So not only at the national level, but certainly also with authorities and leaders within the indigenous communities that they were trying to serve with the campaigns. Number 6, promising practice, is to identify populations that could be missed by traditional campaigns by using what we might call nuanced strategies to find them and provide campaign services. For example, in Nepal, campaign organizers and workers noted that migrant workers, students, and travelers, especially during festival seasons, were often missed by campaigns because they were away from their homes. Therefore, it's important for campaigns to really use special strategies or nuanced strategies to anticipate that and to find the missing persons or populations. So one way to do this certainly is to include an activity such as comparing family registers with school attendance records to identify those children who we think should have been present in school but were absent on the day that the campaign occurred, and therefore we need to do some other type of strategy to reach out. This is a screenshot of a data collection tool. In this case, it's really just the informed consent part of a focus group discussion guide created by our colleagues at the International Institute of Health Management and Research in New Delhi, India. And again, this is just one of the tools that is now available to other campaign planners should they want to have examples of what types of data collections might be appropriate and useful to them for integrated campaign. Promising practice number 7 relates mostly to micro planning. Promising practice 7 is to meet the information and knowledge needs of the integrated campaign by harmonizing tools, templates, and guidance from standalone campaigns, and to do so early in the campaign timeline. For example, in Nigeria, the organization supporting the National Malaria Elimination Program noted that an electronic dashboard was very useful for monitoring campaign progress. The dashboard provided real-time information that was used to support training, deployment of human resources, logistics, community mobilization, and just intervention distribution, in this case, ITNs. It was reviewed daily by program implementers and informed the actions that were taken the following day. So it's extremely helpful to them. Promising practice number 8 relates to supply chain and logistics as well as to data collection. And that promising practice is to use technology and digital tools to facilitate campaign activities, including supply chain and logistics management, or meetings and trainings, real-time monitoring of campaigns, etc. Technology and digital tools used by case study awardees included video conferencing, like the platform we're using now, SMS or text messaging, electronic dashboards, as I was describing before, and also things like health management information systems and digitized beneficiary lists. Promising practice number 9 is most closely related to social mobilization and communication. Promising practice 9 is to increase community acceptance of integrated campaigns by using timely, transparent, and tailored communication, and enlisting the support of community leaders or influencers. For example, in Nepal, the case study awardee described involving community and trusted leaders in campaign implementation by asking them to publicly demonstrate or model the taking of, in this case, antifilarials, along with medication that was provided or that was given to the patients for hypertension and diabetes. This was a way to mitigate concerns among some community members that taking those medications together could be problematic. So a public demonstration was very useful. And we see this happening in many countries and across case study awardees as well. And finally, promising practice number 10 is mostly related to training, engagement, recognition of staff, as well as supportive supervision. And this promising practice says that to set campaign workers up for success, we really need to provide appropriate training, supportive supervision, incentives, recognition, and promote transparency and accountability that are needed for timely payment or remuneration. For example, in Uttar Pradesh, India, the awardee described providing campaign workers with a single training manual in the local language that detailed the integrated campaign activities to promote a systematic and unified process for campaign delivery. So in other words, instead of giving them 2 different manuals and saying, use this one for this campaign and this one for the other, one manual was developed to really support that integrated campaign. They also recognized community health workers in an annual event called Asha Day, which is to recognize and reward their very best community health workers in the state. Finally, this last screenshot here just shows yet another example of a guidance tool. This one happens to be guidance on integrated campaigns. That's an important part of worker training and supervision. This is a screenshot, of course, of just the top half of the first page of the guidelines that were developed by UNICEF to support integration of polio and vitamin A supplementation campaigns. So with that, I'm going to turn it back over to Eva to provide some concluding remarks.
So we believe that this was one of the first efforts to document promising practices in campaign integration planning. And these practices were grounded in these 8 studies that occurred in 6 countries and touching on these various health domains of immunization, polio, malaria, vitamin A, and neglected tropical diseases. And it was informed by stakeholder views at multiple levels, including at the community level. It did allow us to develop a framework that helped us organize the practices, but it can also be a forward-thinking tool that we believe can be expanded as new evidence is collected and added to it. We do hope our website can also serve as a repository for not only for these case studies and other reports, but also tools and other resources. So with that, we conclude our presentation and we look forward to your questions. Thank you.
Thank you, Eva and Carol. Without further ado, I would like to introduce today's panel, who will provide a reflection on the practices presented and insight into their applicability. As I make introductions, feel free to raise your hand using the reactions button at the bottom. Then you click raise hand. Feel free to raise your hand to ask questions to the panelists, or type your question in the chat. We will do our best to get to all the questions in the next 20 minutes. So if your question hadn't been addressed, again, there's time for dialogue. Feel free to exchange information in the chat or link up with us and other members of the coalition on LinkedIn. So first, I would like to introduce Dr. Ajay Kara, Country Representative for Engender Health in India. Dr. Kara serves as the chair of the Health Campaign Effectiveness Coalition Campaign Integration Working Group. Before joining Engender Health, Dr. Kara was a maternal and child health commissioner and public health specialist at the Ministry of Health and Family Welfare in New Delhi. Welcome, Dr. Kara. Dr. Preetha GS is a professor at the International Institute of Health Management Research in New Delhi, India. Professor Preetha led one of the collaborative planning case study teams. The team explored the potential integration of NTD control programs in 2 districts of Uttar Pradesh, India. In their study, they assessed stakeholder perceptions and beneficiary satisfaction with integration of campaigns for NTDs and other interventions. Welcome, Dr. Preetha. We are also joined by Dr. Havana Ocampo, who is a professor at the Universidad de los Andes in Colombia. Dr. Ocampo also led a collaborative planning study team. Her team studied participatory microplanning for disease campaigns with indigenous communities of the river Cubiu. The primary objective of this case study was to identify which health program and disease prevention strategies could be applied to reduce the prevalence of trachoma and STH in indigenous communities in the area known as Cubiu River in Valpes. Dr. Ocampo will be speaking in Spanish, so just a reminder, please select your preferred language at the bottom of your Zoom chat by hitting or clicking on interpretation. Again, I invite those with a question for the panelists to raise their hand, and using the reaction button at the bottom of your screen, you can also type a question in the chat, and I'm just monitoring that. The first question is for you, Dr. Kara. Your professional experience has afforded you a view of health programs and campaigns in all their phases. In your opinion, Dr. Kara, what is the most critical action that those who are responsible for campaign coordination and macro planning must take in the pre-planning phase, that's 60 to 9 months, 60 months to 9 months, to foster collaboration among those who lead campaign activities such as community engagement, microplanning, supply chain and logistics, training activities, supportive supervision, and also data collection, those campaign activities we saw in the table that Eva and Carol shared.
Oh, thank you very much, Lee. First of all, for introducing me as a panelist. And I will respond to this important question, which refers to the specific actions which must be done in the pre-planning phase to make this, integrated campaigns successful. Now, as you just now made a reference that this particular pre-planning phase ranges from 9 months to 5 years. So that means that particular phase is most critical phase, particularly when we are talking about integrated campaign. And in this particular period, there are a number of activities which revolves around advocacy, buying in by various stakeholders. A lot of advocacy is required, lot of coordination, collaboration is required. So one of the action which could be carried out is the establishment of a coordination body. That coordination body takes care of the advocacy with the policymakers. It takes care of the advocacy with the various stakeholders, because after all, we are trying to take various, all campaigns put together. We are talking about integrating, various projects. So, we might have to take all these people, together. Things like, negotiations, things like budgeting, and even assessing the readiness for the campaign integration. All these factors needs to be assessed. And I think the coordination body establishment is one important action, which can deliver all these activities. So I stop here and thank you very much.
Yeah, thank you. Thank you. And I do have some follow-up questions, particularly on the establishment of coordination bodies. So we'll get into that. But first, I want to just ask about the studies and direct my next question to Dr. Preetha. Dr. Preetha, I hope you're having a great day today.
Pardon?
I hope you're having a great day.
Sure, sure.
Good evening.
I'm having one. Thank you so much.
Good, good. So your team studied LF and STH, screening for high blood pressure, blood sugar, monitoring of childhood immunization, and COVID-19 communication as campaigns, and that was for potential integration. Your study found that monitoring for child immunization and high blood pressure screening was not feasible for integration. In terms of the campaign activities Carol and Eva's walked us through, can you explain why both of these activities, monitoring for childhood immunization and screening for high blood pressure and sugar, were labeled as not feasible for integration? Were labeled as not feasible for integration, and maybe share any other challenges your team may have encountered.
Thank you very much, Leigh. Greetings to everyone from IHMR Delhi. So at the outset, I would like to share with everyone that Uttar Pradesh is a state with many health challenges, but we see the state making rapid strides in achieving positive health outcomes as of now. There is a strong intention. And it is also a state where campaigns happen back to back. As shared with us with one of our partners, he said, any particular day, we are either pre-planning or planning or implementing a campaign. So the integration of campaigns is very strongly justified. So with regard to this project, our study districts were Gorakhpur and Devriya. So we proposed that we would explore ways to integrate lymphatic filariasis, the service delivery aspect of lymphatic filariasis, deworming, childhood vaccination monitoring, COVID-related information, as well as screening for high blood pressure and blood sugar. So then, but during the course of our interactions with the various stakeholders, we found that childhood vaccination monitoring, which is a very high profile drive by the national government, which is carried out in high focus districts, was not being carried out during the 2 previous years. That is because the 2 districts were not high focus anymore. They were able to achieve a decent 90% childhood immunization coverage through their routine immunization program, and campaign was not needed anymore. Though it is different now, but during the time of a data collection. So what our respondents across the district, blocks, and also down to the villages, what they repeatedly, they tried to reinforce was that any campaign which was not locally relevant, which was not a local priority, was not supported by the central and the state government, would be operationally very difficult to carry out. So that was that's a very strong facilitator, in fact, for campaign integration also. We are talking about integrating a particular campaign with another one. So without a state or central or state government support, it would be difficult to carry out. The local capacity, it would be beyond the local district level capacity. So that was one reason why we suggested that, why we finally recommended that, since Mission Indradhanush, as it is called, was not being carried out in these 2 districts since 2018, we would rather not make it part of our plan for integration. Though again, having said that, I have to say this month, MI4, Mission Indradhanush 4, is being carried out in all districts of Uttar Pradesh. With regard to screening for high blood pressure and high blood sugar, we thought, at the time of proposing, we thought that would be relatively easy because it is part of the national program for non-communicable diseases. Blood pressure checking and blood sugar checking could be easily carried out by the village level worker Asha when she would be visiting the homes. But then during the course of the study, we were proved wrong again. We found out that Ashas are not trained in checking for blood pressure or blood sugar. So it would be a large scale effort to train all of them. The next in line was the Asha supervisors who were actually trained in, who knew how to take blood pressure and blood sugar. But then there was only one Asha supervisor for 20 Ashas. So then we could very well imagine how it would be difficult for integrating a MDA or multi-drug administration for LF and blood sugar and blood pressure checking, because Ashas are there for every village, but the Asha supervisor is at the rate of one supervisor for 20 Ashas. So that would be 20 times the effort for a Asha supervisor, or else it has to be in a camp mode. So that would be like existing on its own. So it would be difficult to integrate screening for NCD along with a service delivery campaign for LF. That was what we found out. So to sum it up, along these two examples, we found that local context, government, national and state level support, managerial, technical and leadership, these are all very important facilitators for integration of campaigns. Thank you.
Yeah, thank you. And something you said was key too, is that at any time, at any particular time, health workers are working across the phases, and the scale at which the ASHA supervisors work. That is news to me. That 20 we would be adding 20% or 20 times the management training supervision work. Using integration there. Thank you so much, Dr. Preetha. We do have a couple questions coming in from the chat. And the first question I am going to direct to you, Dr. Havana, and I'm just going to read it from the chat for our collective benefit. Mr. David Gittleman writes, the studies identified community engagement as an important, promising practice for integration. What challenges do the panelists see in advocating with community members and training and monitoring the quality of community activities in integrated campaigns? What different levels of effort must programs anticipate to ensure community members are on board with an integrated versus standalone campaign? We're aware that a malaria program in a West African country decided against an integrated campaign because the communities rejected the extra work and complexities involved in implementing it. So to your point, Dr. Preetha, but I'm going to direct that question to you, Dr. Havana.
Muy buenos días, buenas tardes y buenas noches a todos y todas. Un saludo desde Colombia.
Good morning. Greetings from Colombia, from the Universidad de los Andes. Thank you so much for this question. And I think that the first thing is that definitely the work with communities, it's a really challenging work. The first tool that we must have as a fundamental tool, we need to have trust. And that is where I believe that was our fundamental pillar. That is what enabled us to make the community part of this integrated campaign. How was that done? First of all, in Colombia. And this is in South America, just like many other countries in South America. And our indigenous communities and minority communities have had a very important role in our health systems. whether it's because they have wanted to validate their practices or because they have participated directly in formulating many of the strategies for promotion and prevention. In the case of Colombia, that is what happened. And through the Ministry of Health, we have prepared or established an intercultural policy that has identified the promotion and prevention practices for these communities. So that is how we took a fundamental step, and that was to collaborate with the local health systems. And those local health systems had already been working for years in those territories. So for us as a university, we cannot impose anything to them. We can definitely had to work in a synergistic fashion with all those actors that are already in the communities, that are in the territories, that they know their own difficulties, their own problems. And starting there is where we offer these possibilities, new practices, identified by the health system, or those offered by the international guidelines. So the second part, we created work groups, and in those work groups we discuss these promising practices with them, and they see the pros and they see the cons of all practices, and they see the possibility of applying this throughout their territories. And that is how we reached consensus. We agree with each other. Obviously, we have discussions with each other, but we also agree with each other to decide exactly what will happen in those territories and what are the things that will not happen there. Once we have identified those practices, we build upon them together. But all of this is based on trust. And we build together those practices using their own language and using our language, something that really responds to the needs of the community, based on a diagnosis that was made with them. And for that, we need a third element. We need to do a review of the situation, and we need to do it in the territory. We need to do it on site. And we do it, of course, at the national level, but we need to go to their place, to their territory, and that allows us to find other things that will guide our interventions better. And with all these elements and with this tool that we built together at the university, we started identifying what their priorities were, and together, along with the community, we discussed those priorities and we identified what practices we were going to use, the practices that we're going to use for prevention and promotion. And we started establishing the strategies and the actions, short-term, medium, and long-term. And these short-term actions responded to priority needs. And this is what generated more trust, because we were able to respond to their immediate needs. And we really responded to their trust, and we were able then to build a road so that we could work together long term. Thank you so much.
Thank you, Dr. Havana. I really appreciate that. And I think others do too. What I heard was offer possibilities, really build together, review the situation on site, and allow those activities to be led by the community's priorities. Thank you. We have another question from Zwedi at Jimma University in Ethiopia. His question is, referring to campaign integration, what is the focus? Are we talking about a one-time event or more sustainable or lasting integration? In relation to this point, how does the establishment of a coordination body needs to be understood in practice? It reads like a temporary coordination or temporary integration. And I think his second question is, is there any experience regarding effective strategies to control or manage disinformation efforts at the community level? So Dr. Preetha, I'm going to ask you to answer the question on coordination bodies. I know that you had some experience in convening or being part of a coordination platform. Can you tell us about that? Was it convened at the state level, the national level? Who convened it? What decisions are made? And how do those coordinating bodies really serve or benefit those within the community?
Thank you again for this question. This project was a very different experience to us. We keep doing projects. Our IHMR is known as a health system research organization, but this was a project which gave a lot of new learning for us. It was a new area totally. And similarly, we encountered many challenges along the way, like COVID second wave, natural disasters, etc. But what was very encouraging was how we all came together. We had great advisors like Ajay Khera sir, Dr. Satish sir, Path, who was the other organization, one of the other grantees, who was also in Uttar Pradesh, gave tremendous support to us in getting across to all stakeholders in the field. So somehow we continued that relationship with the district authorities, state authorities, other stakeholders, etc. So at the end of the project, we had a state level dissemination workshop where we shared our main findings, key findings. This was attended by about 35 stakeholders from the government and also the partner organizations. It was a hybrid meeting. It was also attended by academicians, state and district level partners, officials from the government as well. So there, when we discussed our findings, many, of course, we were lauded for our efforts, but some gaps also came across. For example, there is already a program which is called Dastak, which is actually an integrated communication and surveillance campaign, which does integrate certain diseases, but there is no service delivery component. What about some evaluation data, which is certainly not the scope of our study, but what we decided there together, the providers, the policy makers, the partners, everyone, what we decided together was that we have to continue this work forward. What evidence gathering, what perspective gathering which we have done now has to be continued forward. We have to get at hard data, quantitative data also. We have to pilot and see what works, what will work with what. Is a partial integration, will a partial integration suffice for certain programs? What will be sustainable? How can local context be considered? So many questions are there. So what we have decided now is that we'll continue forward this work. At the next opportunity, we will pilot what we have proposed now. So the work is on. We are already started work. We are discussing. We are in discussion with the state government, and we will carry forward this. That's what we have. I can say at this point of time.
Well, you have a full coalition who would like to walk along that journey with you, Dr. Preetha. We're very interested in your journey and what you learn along the way. Thank you.
Thank you so much.
So to everyone online, to the panelists, we have about a minute left, and I am going to ask Dr. Ajay Khera to answer this very last question really in a couple seconds, if you can, Dr. Khera. But so that everyone knows, we will post these questions. The questions will go to the panelists. They'll have an opportunity to respond to them. They will, those responses will drop in your inboxes, okay? Or they will be delivered into your inbox. Prior to the and this question is by Desiree Stewart. And again, there are great questions in here, Dr. Khera. I know you can see them as well. But this is from Desiree Stewart, and I think a good place to land. Prior to the pre-planning stage of campaign integration, you talked about buy-in earlier. How is buy-in achieved, assuming that one entity or department or team proposes integration to another? Do you have suggested approaches? Let's see. Do you have suggested approaches for stakeholders to assess the potential benefits of integrating interventions?
Absolutely, Lee. I think the point which is being raised and the solution for all this is, I think, very high level advocacy is required. I am finding a lot of,
Oui, ça va, merci, ouais.
hello,
Oui, la matinée.
hello. Yeah,
I think you can go ahead.
I can go ahead. Okay. So the important point to note is, good level of advocacy is required. And, we also now there's a high time that we need to develop, user-friendly guidelines. Because I am finding the variety of questions which indicates how do you manage such a supply chain when 2 or 3 campaigns are being integrated, And then the point on coordination body is nothing like one time and nothing like sustainable. It all depends on the way the system improves. Because after all, campaigns are required only in those places where there is a deficiency in coverage, And if your health system becomes active, health system becomes normal, you don't require campaigns. So the answer for some of those questions is that this is not a one time and not a sustainable, but till the time the system gets improved. Thank you very much. I stop here.
Thank you. Thank you. So we're going to transition now, but we can continue this conversation in our breakouts. And please refer to the questions that were asked so that we can address those in our discussion. There will be 2 concurrent sessions that we're going to break into, and they're facilitated by 2 members of the Health Campaign Effectiveness Coalition. After 25 minutes, the facilitators will switch rooms and share insights they gained from the first discussion. At that time, you'll build on the insights from the previous discussion, adding additional considerations and recommendations for how the coalition can influence systems change. Please just be courteous in your responses so that everyone can have a chance to respond. I'm going to introduce our facilitators. Ms. Pooja Pandey Rana will facilitate the discussion on how decisions about integrated campaigns are made. Ms. Pandey Rana is the Chief of Party for the USAID-funded Suhara Good Nutrition Program implemented by Helen Keller International in Nepal. Ms. Rana provides nutrition programming guidance to the government of Nepal and program partners in defining, implementing, and monitoring the project's strategic approaches and annual work plan activities consistent with grant requirements. Pooja has 20 plus years of experience in program management, community-driven development tools, primary healthcare systems, performance-based monitoring and evaluation. Our second facilitator is Dr. Santiago Nichols, who will facilitate a discussion on the extent to which global and national policies incentivize or hinder collaborative work. Dr. Nichols is the Regional Advisor of Neglected Infectious Diseases at the Pan American Health Organization, where he manages the technical cooperation of PAHO member states in order to strengthen their national programs for the elimination of neglected infectious diseases and achieve the public health goals established in the Plan of Action for the Elimination of Neglected Infectious Diseases and Post-Elimination Actions. In addition to he also oversees the Disease Elimination Initiative, which is a policy for an integrated, sustainable approach to communicable diseases in the Americas. This policy sets the goals for eliminating more than 30 communicable diseases by 2030. PAHO's targets, of course, are aligned with those with the WHO NTD Roadmap 2021 through 2030 and contribute to the achievement of the SDGs. In these sessions, the Health Campaign Effectiveness Program team will listen for factors that enable and hinder decision-making and collaborative work, in addition to ways vaccination rollout presents opportunities and what the coalition can do to enable change. So those are the key points that we will be documenting in the discussions. We will share a practical recap summarizing your insights following today's session. And at this time, Debs, I will hand it over to you. Good to see you, Santiago and Pooja. I'm glad you both are here. Great, I think we're all back. Excellent. If I don't know if you could see it on my face, but if you were as excited about the conversation and engaged in it as I was, just put a 1 in the chat. I think there was a great discussion there. So I will, we're going to go ahead and kind of report out on what we heard and reflect back to you. I'm going to ask Pooja to join me, and also Santiago to please join me so that we can hear a reflection of what was heard. So starting with, is Pooja here? I know her connection dropped for a moment.
No, I believe Pooja dropped. I'm happy to offer a few comments as the note taker. I'm a poor understudy, but if that's helpful, thank you.
No, you're a great understudy. Thank you, Ali. Please do. So Ali Snyder, as just a matter of introduction, is the project manager for the Health Campaign Effectiveness Coalition. So thank you, Ali. So you and Pooja facilitated discussions on how decisions about integrated campaigns are made. So can you summarize what you heard in those groups? And particularly, did you hear any patterns?
Thank you, Leah. I'll try to be brief. We looked at this around capturing some of the existing enabling factors around decision-making for integrated campaigns, as well as evaluating or capturing some things that may be currently hindering this process. So existing enablers include kind of this practice of being able to demonstrate where there may be a win-win opportunity for each of the campaigns being invited to have these integrated planning conversations and making these joint plans. And this is something that should continue. In the latest group that we just convened here, we focus on the advocacy kind of opportunity side of this, and opportunities for the HCE Coalition and all of us here together and beyond to build kind of an advocacy a suite in a way to be able to demonstrate some of these win-win opportunities. We also heard from folks that that there could be a perception that you're taking away services from a given program or campaign, and that's something to be aware of and maybe be able to speak to. Another kind of hindering factor that was raised were around understanding the real denominator or baseline and having that kind of data-driven planning component and how that needs to be addressed. So the final opportunity that I will share from the notes were around shared tools and helping people kind of start at a point where some of the groundwork is already laid and we can take advantage of tools that help kind of improve the efficiencies of the planning and of those involved. Thank you.
Thank you, Ali. And Dr. Nichols, over to you. Oh, I think you're on mute. Yep. You're still muted.
Yeah, no, I clicked the wrong button. So we had a very good discussion in both groups, actually, regarding the question of to what extent do global and national policies incentivize or hinder collaborative work. So I will highlight the main points, maybe not all of them, but what I consider are the main points arising from the discussion. First of all, there were sort of two two situations regarding the existence or not of policies. It was mentioned that in some countries there are no policies that enable integration. So this would require a lot of advocacy with policymakers, etc. And also the issue that, for example, there are sometimes, as there is no policy for integration, there are a lot of campaigns going on. So this month there's X campaign, the next month there's Y campaign, and people are working all the time either and implementing the campaigns or planning for the campaigns. So policy is needed basically in some countries to facilitate integration. In other countries, there are policies, but they have not been fully implemented. They are only partially implemented, if at all, but the policies exist. So there is a need to actually better implement those policies, and the communities are not fully aware of the existence of these policies, which makes it difficult also to implement, no? Also, a point was raised on how to implement policies, particularly not only within the health sectors, within health programs, but with other sectors, no? For example, education, WASH, environment, and others, which is crucial for the control and elimination of neglected tropical diseases. Also, there was some discussion as to the role of international donors, because there was somebody mentioned that sometimes the international donors actually earmark their donations, and sometimes or most of the time they do not incentivize integrated campaigns, but rather sort of vertical campaigns. So this also, there is some room for improvement in this, and to work with the international donors for them to also integrate the campaigns. And also, Christine mentioned that they are doing a landscape analysis and competing and financing analysis for health campaign effectiveness. So this once this is finalized, I believe this would be a very good input. Also, we cannot ignore the minorities, for example, the ethnic minorities, indigenous populations, and Afro-descendants in the Americas, for example. And I think that's more or less what I would say, that summarizes the discussions in our group. Yeah, and that's what I would say. There were other points that were mentioned, but I think that those are the sort of main points that address the questions that we had to answer. Yeah.
Excellent.
Okay.
Yeah, these are excellent discussions. Quite a few areas that we can further explore. I heard, opportunities were really resounding to me. I heard some hopefulness, particularly in how structures and systems that were set up or have been set up due to COVID can continue to be used in the future.
Oh, yes.
Also, partnership was a theme that I heard. Partnership with communities and growing and developing, establishing partnership with the ministries of health as well. And lastly, that the theme of inclusion in decision making, be it people within the ministries and the communities. So there's quite a bit there that I myself am hopeful for. How about you, Santiago and Ali? How you all feel? Thumbs up. Lots of work to do. Yeah, lots ahead of us. But as a coalition, I know that I know that we can achieve much. So thank you both for facilitating that discussion. And I appreciate both of you. I'm just going to go ahead and close us out. Okay. So we have two quick polls for everyone on the line. Russell, if you could bring those up for me, please. There's two questions I would like to ask you all. One, did you learn something new about collaborative planning today? Or did this session reinforce something you already knew? I'll just give you a moment to answer that question. Did you learn something new? Or did this session reinforce something you knew? If you could just rapidly hit one of those options there. Okay, let's go ahead and show the results. Excellent, almost an even split. Good. So again, as we continue our discussion, especially for those who this was reinforcing to you, continue to provide input into the dialogue sessions. More test and learn sessions will come up, and you'll be notified in your email. Second, the second poll, what would you like to cover in future sessions, future test and learn sessions? One area or one theme, I'll give you a moment to answer that, but I'll just say one theme that came up was cost. How much does this cost? How much does it cost to integrate? The team is but developing and getting ready to plan another test and learn session in June that will cover social economic costs, different studies that have been commissioned, and we will dive into that subject matter. So that's one you do not see here, but please still go ahead and select a choice that will let us know where your interests lie. These are also aligned with those activities you saw in the framework earlier presented by Dr. Bazant. Okay, let's go ahead and show those results. Okay, excellent. Thank you. And you guys can go ahead and scroll through those for your knowledge. And I'm just going to say thank you. You can always connect with one another. You can share your thoughts, your comments, and opinions on the Campaign Effectiveness Coalition's LinkedIn page. That's a good place to connect up with one another and drop comments about this, or leave comments about this test and learn session there, and any lingering questions you may have in between the time of us departing and the time you receive your summary email of this session. If you haven't already, please go ahead and view the full collection of the case studies and collaborative planning that we learned from today. You can do that by visiting campaigneffectiveness.org. Thank you so much, and have a great evening and the rest of your day, wherever you are. Thank you.